Good evening to everybody. I would like to welcome you to our Zoom meeting tonight. There are people that are linking in from all over, Harare and other countries, the whole of South Africa and Johannesburg. You're most welcome. I hope you're enjoying this talk tonight. I would like to introduce Dr. Helen Jager to you. She is in practice with Professor Roux. She's also been mentored by him since she was a little child already and then a student. And he always is available for all the questions she has, and she's learned a lot from him. So she's her own person by this time. Dr. Jager is a general ophthalmologist. She has a lot of interests, and she also has a very big special way of dealing with diabetic people. I know she knows when they're telling fibs, telling her that they know their numbers and their blood sugar levels. I would just like to make a mention that you are welcome to ask questions as we go, but please just type them down. We will only deal with them after the lecture. If you have to run out and say goodbye, you're welcome to send us your questions on an email, and we will gladly answer them afterwards. I also just want to quickly say thank you to Henk and Caitlin. They are our technical team. They will deal with everything behind the screens. Dr. Helen, thank you very much for your trouble and for being here, and we're looking forward to listening to your talk.
Thank you, Louise, for the kind introduction. I appreciate it. I'm just going to put my, before I put my share screen in, I want to say good evening to everybody. Thank you for listening in tonight. I think this is a first for me, so accept that we might have a little bit of glitches along the way, and please ask any questions as we go along, and we'll do our best to answer it at the end. So let's put the share screen on. There we go. Just give me a second. Okay. So tonight I want to speak about the painful eye. As you all know, I think the best approach is a practical approach. And I think because I love anatomy, I usually start with the outside of the eye and then we go all the way inside. So before we start the rest of our lecture, I would like to start with a poll question number 1, just to check our audience's public knowledge a little bit. So Henk will put that on for us. Let's just give him a second. So while we wait for that, let's start so long with the areas that I want to discuss. So if we talk about causes of eye pain, I think we all see patients on a daily basis, and we need to make sure who are the patients that we need to sort out and who's the ones that can be sorted out at another stage. So there's some things that we can't miss. If we start with around the eyes, we start off by looking on the eyelid side. We're looking especially at something like shingles, temporal arteritis. Now, some of you might not ever have seen it, but if you see it, that's something that we can't miss. Then we're going to go talking on the surface of the eye, the cornea and the conjunctiva. Then to the inside part of the eye, uveitis. And then the one thing that I think everybody thinks about when you talk about a painful eye is the acute angle closure glaucomas that we know we can't miss, and also optic neuritis. If we then go to behind the eye, we're going to talk about proptosis causes that can cause eye pain. And in there, we're also going to talk a little bit of headaches, which I think is quite a frequent symptom at these times that we have at the moment. And then also a little bit about pain after eye surgery, and nowadays the intravitreal injections of Avastin and Vitreal S that we do. So if we start off by looking at around the eye, so those patients that often comes, I think, to your practice even first as well, is the eye with a painful eye, red, swollen eyelid that you can see there on the left-hand side. That is a stye. So it's an infection of the oil gland that's next to the hair follicle. Then we get the internal hordeolum, which is the deeper set one. Remember, chalazion by definition is actually not painful because it's not infected. It's just a chronic obstruction of the meibomian gland. So if it's painful, it cannot be a chalazion unless eventually if a chalazion becomes infected. So how do we treat it? Well, definitely, I think you can start with the basic treatment of warm compresses. I think we underestimate the basic stuff sometimes, but if you take one of these cotton rounds that you buy at Clicks or Discount or any of the pharmacies, and you put a little bit of warm water, you squeeze that extra little bit of water out, and you put it on that painful eye for about 5 minutes, 3-4 times a day, or even more often, you can really help to decrease the swelling. If you can see exactly where the pouting of the pus is, if it's next to an eyelash, you can even really try showing that, removing that eyelash and then a little bit of pus drain, and then you've actually sorted out the whole problem. We will definitely give them a little bit of antibiotic ointment, which you can also prescribe, the Chloromex ointment or Fusifelmic twice a day. If it gets more serious, that the whole of the eyelid is involved and the lid is really swollen and the patient can even develop a fever, then we must give them oral antibiotics. So for that, they're going to need referral. So if we look at antibiotics and steroids, a little bit of steroids help a lot, the topical ones, because they help the opening of the oil gland opening up. So then it possibly can drain without you having to cut and incise and drain it. What can we also tell our patients to help if they get it frequently is to make sure that they use something like Naviplay for eye cleanse. I think the reps have come around with you guys as well. It's a little foam. You put it on your finger and then you rub the top eyelid and the bottom eyelid on the lashes to make sure you get rid of all the little organisms that likes blocking those little glands. So if a patient has it repeatedly, say 3-4 times in the last 6 months, tell them to get the Naviplay and they can get it without a script and use it as a daily routine. I usually tell them to use it while they're in the bath or the shower. After they wash their hair, wash their eyelids as well. Then we're going into something a little bit more serious. So if you have a patient that presents with pain around the eye, especially if it's on the one half of their face, but you don't see any other symptoms with it as well. So the one thing that can happen, if they then are warned about the possibility that if they then develop blisters on their skin, this is shingles. So shingles can present in any part of the body, but the one that's dangerous for us if it comes to the fifth cranial nerve, and especially the second division over the eye. So if you then see pain around the eye, red painful eye with blisters around the eyelids, and especially if the tip of the nose is involved, we know there's a very high chance of the eye getting involved. So they will present initially with a tingling sensation. It will never cross over the midline. So it will either be on the one half and not on the other half. And then if they start seeing blisters, it's very important so that they can then start seeking medical attention. So they need to go onto antiviral treatment as soon as possible. So what is ideal? Within 48 hours after the blister starts. What happens if we see them after 48 hours? Well, we're still going to give them a course of antivirals because zoster virus can be detrimental. It can cause corneal scarring. It can even affect the back of the eye. So pain around the eye with blisters, refer them immediately. Make sure they get sorted. Even if there is a GP next to you in the mall or anything like that, they can also start them on antiviral treatment. But it's important that we start as soon as possible. They can get after that a post-hepatic neuralgia that can last for years. So you can really help saving a patient's pain by sending them as soon as possible. Then this is also the one that can be very dangerous. So pain from around the eye, okay, more towards the temple of the eye, so on the side, they will complain that when they eat, when they chew, that they get jaw pain as well, and then it's followed by sudden vision loss. So if you saw that patient eventually with vision loss and you asked if they have any pain around the eye, and they go and you look on, if you look at that top picture where the artery there, the temporal artery is dilated and painful, this is a temporal arteritis. These people, they can die. because it's an inflammatory condition affecting the arteries. The same arteries that goes to our temporal artery and our eyes also go to our brain. So they can die from a stroke if we don't urgently treat them. So if you look at the fundus, if you are able to do that and you have enough time to be able to look further in there, they have this chalky white optic disc. If you see it, you will know exactly what it is. Nothing else will look this white and chalky like this. They can then also get some retinal cotton wool spots. If you looked at their pupil responses, they'll have a relative afferent pupillary defect. That means that if you shine a light into the eye that is affected, the pupil will not constrict. If you shine a light into the other eye, both pupils will constrict. If you then go back to the eye that had the arthritis in there, it doesn't constrict. So what do? We have to treat them on very high doses of steroids. We usually send them to the neurologist for further management. We can diagnose it also on a blood test to see if there's an ESR positive, and eventually somebody has to take a biopsy of that to confirm the diagnosis. So temple pain around the eye, sudden vision loss, and pain on chewing, please look out for temporal arthritis. You can save a life by making that diagnosis. It's not that common, but if you see it, please be on the lookout. Okay, so before we go ahead and we go onto the surface of the cornea, I just want to see if we can get a poll question again there on, have anybody of you seen a COVID positive patient in the last 3 months? So let's see what gets while we're waiting for that answer. So I think it's been taken the world by storm, and we all need to be on the lookout for how it can present, especially how that patient will actually eventually come to us. So let's give it a few more time. We'll wait for that answer. Okay, so I think all of us are still very lucky. I have a sister that's in Cape Town, and unfortunately, they are not that lucky. They already see a lot of COVID-19 patients. But I think if we ask that question again in the next month, probably 50% of us are going to say yes. So we'll talk a little bit later on that as well. So if we go onto the corneal surface, a corneal abrasion, I think that's one of the most painful conditions that a patient would present you with. They're usually in a lot of pain, they're in blepharospasm, they can't keep the eye open. So how do you make the diagnosis? If you can, put in a local anesthetic drop. That immediately relieves the pain, and you can actually investigate and make sure that you look at it. So the margins of an abrasion is usually clear. You'll usually see on the edge of it, you'll see a little bit of the epithelial cells still left there. So how do we treat them? If you can, put a drop of local anesthetic in there, lubricate the eye as best as possible, and put on a bandage contact lens. You will definitely be that patient's hero if you can just help them to relieve the pain. If you don't have a bandage contact lens, or you're in the middle of the Kalahari and there's nothing available, then you can either patch the eye as well, like strongly patch that eye so that that eyelid can't move over it. That can also help, but ideally we need to put a contact lens over it and numb it. Then after about 2 to 3 days, it's depending on how big the abrasion is, to remove it and make sure the epithelium is healed. If it's not healed after 3 days, rather refer them so that we can have a look. So a subtarsal foreign body. I don't know if anybody of you ever had a subtarsal foreign body. It is extremely painful. I think I was 16 years old, and we actually went to watch a cricket game there at Wanderers, and the wind was blowing some of the grass around, and there was actually a little piece stuck under my eyelid. So obviously I didn't really know what was happening, just the fact that something was scratching my eye terribly. So luckily there was an ambulance man, and he actually was able to invert the eyelid and actually removed it. So I was very grateful for him. So what is a clue if you have somebody that also going to blepharospasm, you can't open the eyelid? Try numbing it if you can with a local anesthetic drop. And then if you can see a fluorescing stain that looks very linear, like on that picture at the bottom, look for something under the eyelid, because that movement of the eyelid causes that linear marks there. So look under the lid. So how do you avert the eyelid? The first important thing is to ask the patient to look down. If they don't look down, you can't turn the eyelid around. So they must look down, put a if you want to, put a cotton bud or something on the upper lid and pull on the lashes. Be careful for artificial lashes because they pay a lot of money to have them in there. And if there's no lashes, it's very difficult, but still try. So again, you would treat it as for an abrasion. After you remove it, add an antibiotic if you think it's organic material, and review it again after 3 days if it's not healed. Corneal foreign bodies. So that guy went grinding maybe yesterday or even the day before, sometimes even longer. They didn't wear their protective eyewear, and then one of the little pieces of metal burnt into the cornea. So the thing with a corneal metal foreign body, it actually burns into the cornea. So you're not going to get it out by squeezing some water over it. I really think you also struggle removing it with a cotton bud. So the best way of removing it is by using a sterile needle, and just with a small bevel, just tilt it out of the way. So if you're not comfortable in doing that, rather refer them and we'll remove the foreign body as soon as possible. After we've removed it, we check to see if there's a rust ring. If there's a rust ring can still continue rusting, so we have to remove that as well. So sometimes you can also remove it with a sterile needle, and sometimes we have to use a burr to make sure that we get it clean off. So before we go further, I want to ask him to give us another poll question there. How many of you have seen a viral conjunctivitis in the last 3 months? Sorry, Ink, I think I've sent you to the previous question. That's fine. Let's just give it a second while we wait for that. Let's go on to the next slide. So if we go and look at corneal ulcers. So corneal ulcers are also extremely painful. So if you don't look at the cornea and put a little bit of fluorescein in there, you might even miss it. So extremely painful, their vision will be worsening, and then we usually group it into 2 big groups, either the viral ones or the bacterial ones. So if we look at the viral ones, usually it's a dendritic type of ulcer that causes these branches branching out. There's nothing else that would look like that. Sometimes an abrasion can sort of make you look, maybe it's a little bit branchy, then you'll anyway treat it as for a viral ulcer. But if it's bacterial, it will be a small little white spot there in the eye. So if you see any 2 of those conditions on the cornea, refer them. They need to be treated as soon as possible. So if we look at a viral conjunctivitis, I think you can give us that, I think it's that 3rd question or the 4th one already for the poll. So if we think about the viral keratitis, they persons need to be referred on that same day. And again, they must be treated with oral acyclovir or valacyclovir. So you can see the poll coming up there. So before we get to that slide, I want to ask you, how many of you have seen, how does a viral conjunctivitis present? Is it a pussy discharge or a watery discharge? Maybe we can give them a few answers or a few seconds to answer that. Well, we wait for that as well for everybody to answer. If you then see an eye that looks like the bottom picture, it has this large central staining fluorescein scar, which is round. The eye is extremely red, extremely painful, and you can even see the pus line there in the bottom of the eye. So if you see any of that, that patient needs to be referred urgently. Why? Because that is a bacterial ulcer that eats into the cornea. If we don't treat it successfully, it can lead to an endophthalmitis and eventually even blindness. So look at the corneal surface extremely well to make sure. So if we look at the poll results, have everybody of you gave your answers already? Louise, do we know how many people there are already? Good. Okay, so viral conjunctivitis, well done. It's definitely a watery discharge. The pussy discharge is the one that presents like a bacterial one. So which one must we be more careful about? Well, which one is more infective? Definitely the viral conjunctivitis. So bacterial conjunctivitis, pussy, yellow discharge, crusting of the eyelid, stuck in the morning. They have to squeeze it open to be able to get all that gunk out. that is a bacteria. Yes, you can probably give it to somebody else, but it's not as effective as the viral ones. So we treat them with topical antibiotic drops or even ointments for 5 to 7 days, and most of them clear up without any problems. Whereas if we think about the viral conjunctivitis and the pink eye, they have a watery discharge. They'll say, my eye is extremely painful, the lids are usually swollen, they can have like flu-like symptoms, they can have a watery discharge, a lot of water discharge. Then if you feel in front of their ears, if you ask them, I usually ask them to feel there, and if they feel a painful node just in front of their ears, then it's usually also quite specific for a viral conjunctivitis. They then also can develop pseudomembranes. So that will usually happen about 10 to 14 days after the initial red eyes. It definitely lasts longer than a bacterial conjunctivitis. How do we treat it? Unfortunately, for most of the adenoviruses, we don't have any antiviral treatment available. The best we do is to treat them symptomatically. So yes, we give them a little bit of cortisone after we check the corneal surface to make sure they don't have any corneal involvement. It does help for the swelling, and it helps to reduce the inflammation and the pain that the patient experiences. It also then presents them or prevents them from getting a subepithelial keratitis with these white sort of flecks that they see on the cornea that can happen after about 2 weeks. So these patients, we always say they usually get worse before they get better. They're going to have 2-3 weeks of a painful red eye. And I all think we know how long can you still infect somebody with a pink eye virus? For 14 days. Okay, so let's go to the next poll question there, Henk, if we can. So the question I think that is relevant for us for today as well is, can conjunctivitis be a sign of COVID-19? Let's wait a little bit and see what happens. What do you think? Louise, have you ever had a viral conjunctivitis?
No.
Me neither, and I really don't want it because I think it's extremely painful and nobody wants to get close to you. Almost like being a positive patient as well, hey?
Absolutely.
Okay, well, we wait for that. So can conjunctivitis be a sign of COVID-19? Yes, it can. So there was quite some studies that came out of Italy. So I'm glad you guys are looking at other webinars and seeing what's happening around the world. But yes, definitely it can be a sign of COVID-19. So I think in our practices, we all see pink eyes every now and then. If you see a patient, be very careful. Conjunctivitis can be the sole COVID-19 symptom, although most of the time they'll present with a fever and a cough and general malaise like we all know, but conjunctivitis can be the only symptom. So can you get COVID-19 from tears coming from the eye? They think so. So we must not touch these patients without wearing gloves, especially if they then have pseudomembranes that we usually have to then remove to relieve their pain. We have to wear gloves and make sure that we treat it as a high-risk patient. So we would suggest that you wear an eye shield, goggles, or at least spectacles. Make sure you wear gloves. Make sure you wear a plastic apron and clean all the surfaces touched by the patient by at least something that has 70% alcohol in it. Avoid contact with other patients. So that patient must not wait in the waiting room. They must not go on the autorefractor and then to the lensometer and then all over. They must go directly to your office. You must make the diagnosis and either treat them or refer them. But please don't let them wait in your office, and please don't let them go onto your machines without making sure that you've cleaned everything very nicely. So we don't want to be the cause to spread the virus to somebody else, so be on the lookout for that. So I'm quite impressed with all you guys making sure that you know about the symptoms of COVID-19. So that was the surface of the eye. Now we go from pain inside the eye. So I think if you have a painful eye that is light sensitive, now yes, the abrasions and so is so light sensitive, they go into blepharospasm. But these guys usually they maintain their eye open. But when you shine a light into their eyes, they want to close the eye up a little bit. The redness usually starts off around the limbus and then it spreads towards the outside parts. And then you see these mutton fat capies. So unfortunately, you don't always see these mutton fat capies, but if you see it, there's nothing else that will do that. Then the pupil is stuck. So you shine a little light in there and the pupil doesn't really want to constrict. When you make the room dark, it doesn't really want to dilate. So this is a uveitis. A uveitis must be treated as soon as possible to prevent all those iris adhesions and cataracts and deeper set inflammation as well. So they must be referred for steroid treatment. And it's usually not a once-off thing. It's something that can be recurrent. And we need to try to find systemic causes for it. So it usually ends up with a big workup to make sure at least we exclude the most common causes. But to refer them, as soon as we can start the cortisone, we can prevent the complications of the iris adhesions and all of that. Then we get to angle closure glaucoma. So they say for every 100 patients that you see having glaucoma, only 6 of them will actually have angle closure glaucoma. So like you all know, most of the glaucoma patients that we see is completely asymptomatic. You've done a pressure test because you are looking to make sure you're looking for other pathology as well. And then you're like, oh, this pressure is 25 or 30 or whatever. This patient will not present like this. It will usually be a female in her 60s and she will have severe eye pain. So much so that it will make her start to go very nauseous and even vomiting as well. Then if you look at the corneal surface, you're still lucky enough to see the inside of the eye and the cornea is not completely hazy. The pupil will usually be a little bit dilated, sort of in an oval shape, and the eye will be extremely red as well. If you then can be able to look into the anterior chamber of the eye, if you shine a light from the side of the eye, that is the eclipse sign, all the light must go through to the other side. But if that angle is shallow, you shine a light from the side, and then there's a shadow on the other half of the eye, then we know it is a shallow anterior chamber. But you've already made the diagnosis in the fact that it's a very painful eye, and if you measure the pressure, if you are able to do so in that painful eye, it's usually more than 50. So those patients needs to be referred urgently. If we don't get that pressure of 50 down within, well, at least every second counts, but if it lasts longer than 3 days, you'll have no optic nerve left to save. So those patients must be referred urgently. So make sure you have our number, our emergency numbers. If you are lucky enough to see one of those patients, because they're not that common, you need to make sure you make the diagnosis and refer them. This is not a uveitis because the pupil is usually dilated and the pressure is very high. Then if we go into an optic neuritis, so pain also usually, this pain is a little bit different from the other pains that we've discussed because they will have pain on eye movements. So they'll have usually present with a sudden onset of vision loss. Pain, not when they're looking straight, but when they're moving the eye, when they're stretching that optic nerve in the bony canal there. They will definitely have a relative afferent pupillary defect. So again, if you look at the pupil responses, if you shine light into the eye, the normal eye, the pupil will constrict. If you then take your light to the abnormal eye, the pupil will not constrict. If you then look at the optic nerve, the margins will be blurred, very swollen, not chalky white like the temporal arteritis, but just blurred margins like this. They need to be admitted for high doses of IV steroids. So also this is one that the sooner we start treatment, unfortunately the optic nerve is in a bony canal. So when it swells, it's going to get damaged. So we need to get the swelling down as soon as possible. And usually this is associated with something like multiple sclerosis. So they need to refer to a neurologist as well to take over the management. So sudden onset of vision loss with pain on eye movement, look at the pupil reactions, look at the disc, refer them immediately. Then if we go to pain behind the eye, so proptosis is the eye moving forward. Sometimes we can miss it a little bit if it's both eyes, but one unilateral proptosis is usually difficult to miss. So thyroid eye disease, let's talk about thyroid eye disease. So that patient there, if you look at a very, very swollen lids, lid retraction as well, usually middle-aged females, and they'll have double vision because of the eye muscles that's also inflamed. So these patients are in severe pain. They usually also have exposure keratopathy because of the lid retraction and the proptosis. There's no way the lid can close over the cornea. So they get corneal exposure, a lot of pain. They need to be treated also with high doses of steroids and referred to a physician to help us to treat the thyroid, and eventually then with the surgeons to do the iron therapy for radioactive iodine as well to burn the thyroid hormones. Then something a little bit else about proptosis. Usually more painful than that is the idiopathic orbital inflammatory disease. So this is a benign, non-infective inflammation of the orbit without thyroid eye disease or any of the other vagus granulomatosis problems. Usually more males than females. The proptosis is usually more just on one side. There's no real lid retraction, so the upper lid won't be pushed up above the corneal limbus there, and they usually don't present with double vision as well. But they are more painful because the orbit gets so swollen with all this inflammation that it really has nowhere to go, and that they also need to go onto high doses of steroids. So before we go further, there's another question that I want Henk to post for us. About orbital cellulitis. So do you think a patient can die from orbital cellulitis? Let's hear what our audience has to say. So I hope you've seen an orbital cellulitis. So that's usually also in our younger patients. Let's have a look what comes out. Okay, so can a patient die from orbital cellulitis? Unfortunately, I've got personal experience. So the only patient that I ever had that died while in the eye ward was a 12-year-old boy. He was in a state hospital. He had a sinusitis, and his parents said, "Oh, don't worry, it's just a blocked nose." By the time he presented to the casualty department, he had an eye that was almost looking like this, completely swollen shut. We couldn't even open it to have a look on the inside. That abscess from the sinuses already broke through into his orbit, obviously, and unfortunately into the brain as well. And it developed a massive brain abscess, and before they could take him to theatre, he died of septic shock. So this is also one of the things, especially in kids, younger patients that frequently have symptoms of allergic rhinitis that develops into a sinusitis. These patients are having fever, they are sick. So they also present with this swollen eye, but that eye you can't even open. So the pain is usually also on eye movement if you can still get it to open up. If they have decreased vision with an RAPD, it's an imminent factor that they might have a brain abscess as well. Because if you think where the sinuses is situated, the ethmoidal sinuses are behind the nose part that we see here. So behind that, it easily breaks into the orbit. And unfortunately, between that part of the ethmoid sinus and the brain, there's a very thin layer of bone there as well. So if it goes in there, they can definitely, unfortunately, get some severe complications. So don't miss the orbital cellulitis. If the patient has pain on eye movement with the RAPD, rather send a patient that has a preseptal cellulitis. So preseptal cellulitis is swelling of the lid, but the eyeball can still move. So if you're not sure if it's just lid swelling, lift it up. If the eye can move and the pupil can constrict, tell them to come back tomorrow or have a look. If it gets worse, tell the mom to see if the eye can still move. If the pupil can constrict, we're still okay. But they need to be put on antibiotics to prevent the severe complications of that. So they must have a CT scan, they must be admitted for intravenous antibiotics, and then the ENTs, usually with the neurosurgeons, go in and drain that abscess. So don't miss the orbital cellulitis. Then I think something that we see quite often as well as people presenting with headaches. I think you guys see a lot of patients that present with eye strain. Is it due to their presbyopia? Is it due to the uncorrected refractive error? Or is it just a real headache? So it gives us a headache to try to sort that out, because it's usually, we're not usually taught about headaches. We think that's the neurologist's problem, but those guys are so full, nobody gets to see them unless if it's really urgent. So they usually present to you thinking maybe it's their eyes, and then they even come to us so that we can also sort that out. So what are the two types of headaches that I think we should really be on the lookout for and diagnose, and then refer it then to the neurologist if we need to? So cluster headaches. Cluster headache is a sudden severe headache centered around the eye or the temple. It's piercing. It's like somebody stabbing you with a knife. That headache can occur in short bursts. And then on the same side of that eye, they can have a runny nose, a watery eye, swelling of the face, and also swelling of the eyelid. So we might think it looks like maybe the start of a herpes zoster virus or something like that. But usually the thing that distinguishes is they usually have this for weeks and months or even years. So this usually happens on the same time of the day. So some people can even be woken up at night, every night, 2 o'clock. They have this piercing pain. They think maybe it's the start of a conjunctivitis or something. And by the time they wake up in the morning, eventually after all this, the eye looks fine. So look out for cluster headaches. So cluster headaches are difficult to treat, but in the eye itself, after that attack of the headache, you'll see no problem. So they won't have uveitis or optic neuritis or anything else associated with it. So we still exclude the other causes to make sure. But cluster headache, that piercing pain, same times of the day, between 45 and 90 minutes at the time, they need to be seen by a neurologist. Usually that they try is to give them oxygen while that happens. One of the blood pressure tablets also help a little bit, or then the cortisone treatment for that as well. So look out for a cluster headache. Ask, is it the same time of the day? Piercing pain just on one side, usually around the eye, and they can have a watery eye and a watery nose. Then we go on to migraines. So what is a migraine? A migraine is an intense throbbing pain on one side, usually of the head. It usually then leads to nausea and vomiting because of the severe pain. And these people want to go into a dark room. They are light sensitive. They don't want to eat. They'll just go to bed and try to sleep it off. Usually they'll have a family history with it. And then some of them, which is quite a high percentage, will have been a visual aura. And these are the ones that usually comes to us. So what is a visual aura? It might be flashing lights. Okay, it might be a prismatic rainbow like you see in that picture there down below. It might have a zigzag pattern of shimmering light that goes all around, but that usually lasts only for 20 to 30 minutes, the visual aura, and then it's accompanied by the headache then thereafter. So they don't have any other eye symptoms. We actually, when you look at the eye, you can absolutely see nothing wrong with the eye. They don't have big floaters flashing by. They don't have a thin retina that could have been caused by a posterior vitreal detachment. So headaches, migraines, ask about the symptoms of migraines. And once you are sure that it's more a visual type of migraine, you can assure them that it's not coming from the eye, that they need to go and see a neurologist to manage it further. So headaches and eye pains can sometimes present to a patient with the same, they usually will hold their head like this. So yes, we must make sure that there's no refractive error. Yes, we must make sure that we correct their presbyopia, but maybe they need a referral to a neurologist as well to sort out the further problems. Okay, then we go on to pain after eye surgery or intravitreal injections. So as we know, we are surgeons, we love doing cataract surgery. We really help trying to treat patients with age-related macular degeneration as well. And to do that, we need to give Avastin into the eyelid centers and Eylea at some key times. So when should you be worried? So if you see a patient after cataract surgery, most of the patients that we see after cataract surgery will tell you it wasn't even painful. A little bit scratchy on day one. Usually after a week when the wound starts healing a little bit, they feel a little bit of an itch. But most of the time it's painless. So if you would come across a patient after day 1 having eye pain after cataract surgery, it's usually because of elevated intraocular pressure or a corneal abrasion, when we do a periocular block to numb the eye during cataract surgery as one of the options, they don't feel around the eye. So they actually, unfortunately, sometimes the eye doesn't close all the way and they can't feel. So if they then get a corneal abrasion, we'll see it on day 1. So then we'll treat it with a bandage contact lens and make sure we decrease the pain as much as possible. But if these patients would present to you after about 7 to 10 days after surgery, that is very high risk for endophthalmitis. So they saw good initially after surgery, now no pain, and then after a week, between day 7 and day 10, their vision starts decreasing a little bit. They get a red, painful eye, and if you start seeing anything white that lies there, making a white line into this corneal, on the inside of the corneal surface, then refer them as soon as possible. So these patients need to go to theatre. We need to make sure that we rinse all that pus out of the eye, give them intravitreal antibiotics, and try to save the eye. So luckily, it is a very seldom thing that happens, but if it happens and you would come across one of those patients, please refer them as soon as possible. They can't delay. They must be treated within the next 2 hours to make sure we save their eye. Now, if we talk about Avastin injections and intravitreal injections, if they then get infections directly after injection, it usually happens earlier than after a cataract surgery. So they will usually then present between day 3 and 5 after an injection. So what is the risk of getting infection after an intravitreal injection? Well, there is a difference between different countries and different techniques, but it's about 1 out of 3,500 people that we inject. So the risk is still low, but if it happens, it needs to be treated as soon as possible. So if you see a patient after any surgery, cataract surgery, LASIK surgery, retinal surgery, or after injection and they have pain, then there's usually something wrong, and please refer them as soon as possible. So if I come to the sort of the end of our discussion, I think we looked at a lot of causes that can cause eye pain. We are clinicians, so our first goal must still be to try to make a diagnosis to see where the eye pain comes from. So have a look at the eye, think anatomically, look around on the outer surface, look on the cornea, look inside the eye and behind the eye with the proptosis and the migraines and that, and especially after eye surgery as well. So it needs a good examination to make sure that you look at the urgent causes. And I think we've nicely gone through all the causes that I think one should not miss. So Louise is also willing to share the slides and with you if you're interested. So maybe if you have a little bit of time, go through it again and make sure you look at the causes that we should not miss and make sure we refer them so that we can treat our patients as best as possible. So before I end my talk and before you run off, I just want to ask one poll question there again before we look at our one of our last slides there, Henk. So are you ready to send your kids back to school? I would like to see what the most common answer for that will be. I think it's the longest holiday the kids have ever had, and they're definitely not used to getting school at home. So let's see what you guys enter there. I also hope that most of you guys are back at work and seeing some patients. And I think from our point of view, unfortunately, we do have to come quite close to our patients as well. So I think it's an interesting poll in the sense that I think we're all scared a little bit. But we know that our kids are all healthy and they have a very good immune system. So we hope our schools will really look after our kids as well, because being at home is also very challenging, especially if you can't be at home anymore, and we all have to be there because we all have busy practices and we need to look after our patients. So good luck with the final decision on what to do with your kids. Well, my grade 1 child went back to school this morning, and I must say I was quite relieved to know that he's in good hands. So being an eye surgeon is not a teacher, so I'm glad he's at the place where they can really help him to be the best grade 1 he can be. So just as a summary again, when to refer, look for foreign bodies on the surface of the eye when pain is due to an injury, if there's severe blur vision and sensitivity to light, pain after any eye surgery, please refer so that we can have a look. Again, be on the lookout for the conjunctivitis patients. And when we started off as being doctors in hospitals, when we first started in our 4th year going to hospitals, we saw a lot of TB patients and we saw a lot of HIV patients. And the prof actually said, you know what? Just think as everybody is positive and make sure you don't let your guard down and be as safe as possible and try making sure that you do all the recommendations that should be done. And we can just do our best to make sure that we keep us and our patients as safe as possible. So look out for eye pain. If there's anything that needs referral, have a look first, see if you can make the diagnosis and make sure we don't miss the stuff that really needs to be seen on that same day. So thank you a lot for listening. Before you run off and get something to eat, I hope those of you that haven't had dinner yet, like me, are all now hungry and ready to spend some time with our family. So thank you for taking the time to spend time with us and listen to me talking a lot. And I hope to see you all in future soon. And then, we never know how it's going to be in a year from now, but if this is the way that the life is going to be, I think it's a nice way of sitting in your home and still learning something a little bit about ophthalmology. So thanks again, and thank you for your referrals. We really appreciate it. And if there's any questions, we can maybe have a look at it. I think we've stayed into our time slot, Louise, so I'm quite impressed.
Yes. I think we're all fine. Let's start right at the top with Margita asking, she always wondered, why does shingles only affect one side of the face or body?
Okay, so I don't see the questions here, but I'm going to answer on what you say. So shingles is actually the chickenpox virus that we had as a child. So it actually goes dormant because we do create immunity against it, but for some reason it likes staying into the neural ganglia. So when your immunity stops a little bit or goes a little bit immunocompromised, that virus gets reactivated. So that virus stays in a nerve. So a nerve doesn't cross from one side of the body to the other side. So it doesn't matter where on the body it is from head to toe, it will only be on one side. So either it can be in any ganglion, you sometimes get it around the chest or on the lower back and even on the bum as well. It never crosses the midline because the nerve doesn't cross the midline. There's always a nerve for the right and a nerve for the left side. Okay.
Thank you. And then there's one, I presume it's Haley Wachsberger, said, do they both present with an itchy eye? I think it's when you were talking about the viral versus the bacterial eye infections. I guess so, Haley, I hope I'm right.
So I don't know, a lot of people will, if they have any symptoms around their eye, will call it an itchy eye. So if you then start asking a little bit more, is it more painful eye? Is it more a burny, scratchy type of feeling? They would sort of maybe go more into that direction. But an itchy eye is a very common complaint for anything that happens around the eye. And they tend to feel a little bit better when they rub it a little bit, unfortunately. So that's also, I think, why they present with itchy. But itchy would probably more sit better in with a papillary conjunctivitis that we see with allergic conditions, especially in the younger kids and things like that. So it is still a possible symptom, but usually more pain than itchiness. But if it's an itchy eye, you anyway have to look to see what the conjunctiva looks at, and look at the inferior and look under the upper lid to see if you don't miss that horrible papillae that kids sometimes have to live with because we don't look there. So, yeah. Is there any other questions?
There's another question. If you have more questions, you can put it under question and answer. But there's another one from Unilla. Do we refer direct to neurologist or do we go through an ophthalmologist first? That's a good question, because you can't get into a neurologist, and the chicken come first or the egg or whatever.
Even we struggle to get hold of our neurologists that we're trying to use, but and some of them are not even seeing urgent patients as well. I'm not sure exactly. I don't see that question here. What is she exactly referring to?
Unilla, do you quickly want to type under question and answer what exactly you're referring to?
What condition that we were talking about, the temporal arthritis.
I'm not sure if Unilla is still there.
So
well, while we
if you're exact about your diagnosis, then the neurologist is the way to go. If you can get hold of them, then please do so. But if you're not sure and we need to have a look at the back of the eye, so we're more than grateful to have a look as well. So get a neurologist on speed dial as well. Okay, so how painful is a severe dry eye? That's the one I see there from Karina. So I must say, I actually wanted to put dry eye in there, but I've talked a lot about dry eyes in the past, so I decided not to. But a severe dry eye can be extremely painful, especially those patients with the Sjögren's syndrome and the rheumatoid arthritis. They really suffer from a lot of pain. So we must not underestimate the dryness of the eye. So if we put that fluorescein in there, the conjunctiva is staining on the sides, the cornea, the whole cornea is staining with punctate epithelial erosions. That's actually extremely painful. So that's why we tend to give them a little bit of cortisone as well, and even more stronger immunosuppressants like the cyclosporin that we have to mix with the tacrolimus, because they are really in severe pain. They need even a little bit more than cortisone, and they definitely need plugs, and they need lubricants and ointments and all of that as well to make sure they get the pain better. But that's quite challenging because it's a chronic condition and they actually have chronic pain all along. So there's where sometimes the scleral contact lenses, for those of you that do that, we really appreciate it, because sometimes we just really can't get it better, and then we'll send them for a scleral contact lens for help for that pain relief as well.
Thank you. And then Unilla answered the neurologist versus ophthalmologist. It's specifically for giant cell arteritis.
Yes. So if you can make the diagnosis for that, they need to go and see a neurologist as soon as possible, because eventually they are the guys that look out for the brain arteries and making sure about their diagnosis. And giving patients high doses of steroids is, you need to admit them to hospital, make sure their sugar levels don't go too high, make sure they don't go into what is byniere in Engels, Louise?
Oh, golly.
They must go, they must not shut off. So we also don't want
adrenal glands. I'm not sure.
Yeah, adrenal failure. So we want them to be in a hospital setting. So that's why we'll gladly let the neurologist admit them and give them those high doses of steroids. So there's also, Natalie gave a question about the topical antibiotics. So I think at the moment in South Africa, you can actually buy Chloramex ointment over the counter without a script. So that's usually what most people go for. The other thing is sulfacetamide. I don't like the sulfacetamide cream that much, because there's a lot of people that's allergic to sulfas. So if you're allergic to sulfa antibiotics, you can have an allergic reaction to it. We see it much less with the other antibiotics and much less with the Chloramex as well. So Chloramex over the counter, drops is a little bit of a problem. I think you need a script for that. So for good entry level, we like the Tobrex, we like the Exocin eye drop, the Siloxane eye drop, any one of those three, but I think you need a script for that in South Africa. So do you also give oral antibiotics to preseptal orbital cellulitis? Definitely. So we're definitely going to keep them on oral. So with the oral, we also still give topical, and we'll give some ointment at night time as well. But no, definitely, we never want to go into orbital cellulitis. So if there's just a small chance, then we'll treat it with oral antibiotics. But that you can give as at home for 5 days, either Ciprobate or Augmentin, and that's usually then sorted as well. So why is dry eye a very common symptom after surgery? Well, I think the first reason for that is people are more aware of their eyes after surgery. And if we don't make sure that we've tested their tear film before the surgery and advise them to pre-treat their eyes and corneas with lubricants before and after surgery, I think it's us sometimes not making sure that we've tested the tear film before the time. And if you ever refer a patient for cataract surgery, if you think they have dry eyes, start treating them already when you refer them. Then we cut through the cornea. So by cutting through the cornea, just as we do with LASIK surgery, a little bit bigger, but we do about a 2.4 millimeter cut to cut through corneal nerves. Once we do that, that part doesn't get good innervation for a while. It does tend to grow back, but it doesn't get good innervation, and then they get a dry eye from us cutting on the surface. And then we can bombard them with topical treatments of the cataract surgery. So there's a lot of preservatives into the eye. Sometimes they can even be a little bit allergic to the eye, or get a reaction with dry eyes as well. So dry eyes is a problem after cataract surgery, sometimes because we've not diagnosed it before the time, but because of the us cutting on the eye causing inflammation, and also all the drops that we put in there as well.
There's one question under the chat from Tsitsi. Chloromex is still scheduled as 4. In my knowledge, it requires a script. Only sulfetamide is available without a prescription.
Okay, so we can actually just confirm that. I'll confirm it with our pharmacist as well. But I know there's people that get it, maybe the pharmacist just scripts it to them. But sulfacetamide, I think, actually have a higher risk of getting an allergic reaction. So it's sometimes interesting to know how the scheduling works. I don't know if it's because it's an older type of antibiotics, but we'll look into that a little bit and let you know. I'll check that for you.
Doctor, these are the questions that I can see. I would like to mention to all the delegates that we've copied this or recorded it, so it will be available probably within a day or 2 or 3 on YouTube, but I will send you the YouTube link, and then you can listen to it again. And I also want to just mention that Dr. De Jager also practices in Pretoria. Is it Murray Street, Dr. De Jager?
John Murray Street, just off the Brooklyn
Murray
side.
Street. It's just, yeah, it's in Brooklyn. So there are a few people from Pretoria that it might be handy to know. And otherwise, she's in Northcliffe in Johannesburg. And for those who are not familiar with Visiomed, we are in Northcliffe. It borders Randburg in Johannesburg. And yeah, we're a private clinic. I think we have concluded the evening. I really want to say thank you again to Henk and Caitlin. We couldn't have done this without your help. Helen, you gave an excellent talk. We had a lot of compliments here. I really appreciate it. And to all of you, have a lovely, pleasant, warm evening. And we'll see each other again. There will be another talk coming up on the 28th of July. I will send you the invitations probably within about a week or 2. Sleep well. Bye-bye, Dr. De Jager.
Bye-bye. Bye.